Good evening, all the aspirants present here. So, today the topic is molecular medicine, and the faculty that we have here today is Dr. Varun Pushkarna, sir. He is a senior consultant in internal medicine, Fortis Escortis Hospital, Amritsar. Sir, you may continue. Thank you.
Yeah, thank you. Thank you, Sana. Good
And
evening, everyone.
And also, for the aspirants, I want to say if any question or queries you have regarding the classes or any question, any topic, you can unmute your mic and you can ask here. Thank you.
Yeah, thank you, Sana. Good evening and welcome all the aspirants. Basically, today's class is of a very, important but a small topic. So, molecular medicine.
এক্সরে গুলো ভালো থাকলে ঠিকই আছে।
Yeah, can you please mute your mic? Okay. So molecular medicine, many times, when I was a student, I had a hard time finding out the topics on which molecular medicine is based. So basically, molecular medicine, it goes back to these topics of genetic basis of disease, some diagnostic tests which are, coming up in a good manner now, and they basically are required for establishing diagnosis of several conditions like PCR, like we did in COVID also, RT-PCR was done. So it is a molecular diagnostic test. Then comes gene therapy. Nowadays, the focus is on altering the genome of humans to treat certain conditions like cystic fibrosis and other conditions, which can be corrected through genetic therapy. Then pharmacogenomics, molecular oncology. Uh, these days, whenever we are talking about somebody having a cancer, they are always talking about some chemotherapeutic agents and then immunological drugs, and then they are talking of some newer drugs which are actually affecting at the level of the genetics. So oncogenetics, that is known as, then epigenetics, and then this new procedure known as CRISPR and genome editing. We'll discuss about it. It is an important upcoming topic, and uh, very soon we will have a lot of questions coming from CRISPR and genome editing, and then the mitochondrial genetics also. So basically, genetic basis of disease is very important. We all understand there are certain diseases which are connected to the genetics, and certain diseases which can be inherited. Some are because of de novo new mutations. In some conditions, the mutations they travel down the family, and then these mutations they continue to amplify themselves, become bigger and bigger until and ultimately when one family member he dies, and then the legacy stops. So we have to understand that all of these inheritances, these genetic depend base of the disease is very important, because not all people who have similar genetics they develop similar disease profiles, because there is some environmental contribution also to the disease. So genetic basis of disease may be with understood with Mendelian inheritance, like we've been studying since plus one, and they are autosomal dominant, autosomal recessive, X-linked disorders. These Mendelian inheritance mean they divide the chromosomes into two types. One is the regular chromosomes, and then there are sex chromosomes. So whatever is inherited through the regular chromosomes, they are known as autosomal diseases, where just one gene is important, as one chromosome is important to carry the disease. It is called autosomal dominant, where two copies are required. It is autosomal recessive. And when a disease is transmitted via the X-linked pathway, that is through the maternal genes, because XX is female and XY is the male. So every male has an X coming from their mother, because father only contributes Y. So whatever diseases are there, the X-linked ones, they travel through the maternal pathway. So mothers give it to their sons, and mothers give it to their daughters, and the daughters are usually carriers, and sons are usually the disease manifestors. So these are the X-linked disorders. Then comes the chromosomes when they are deficient or excess by themselves. For example, human beings, they basically, we have this 46 and 2X chromosomes or 2XY chromosomes. So whenever the 13th chromosome becomes three times, the 21 chromosome becomes three times, for example, that is Down syndrome. Oh, my pen. Yeah, that is Down syndrome. So Down syndrome is trisomy of 21. Then Turner syndrome is when 45 and XO is there. So it's not even 46 chromosomes, it's 44 plus two chromosomes X, and either it should have been X. But because there is no Y in it, the genotype is 45XO and the phenotype is that of a female. Then Philadelphia chromosome is the translocation from ninth chromosome to 22nd chromosome, and it carries a very potent kind of a combination to yield a disease known as CML, which is chronic myeloid leukemia. Then there are mutations which can affect the human, genome, leading to disease onset. For example, sickle cell anemia, where the it is replaced by valine and beta globin gene. Then there is a frame shift mutation. Frame shift mutation usually seen in cystic fibrosis, where it is the F508 delta mutation. So these frame shift mutation leads to cystic fibrosis. CFTR gene is the defective component. The chloride balance is distorted, and all the secretions, they become so thick that they find it difficult to flow, and hence leading to choking of the airways or the any tubular system of the body. Then there are very important diseases which are known as trinucleotide repeat. We all understand DNA. There are nucleotides which have to be in a different setup. But then when a triplet continues to repeat itself, like GAG repeat, then it is Huntington disease, Friedreich's ataxia, so on and so forth. These diseases, they are very important, and they have the genetic basis of disease. Clinical relevance is that we need to understand these mutations, because if you can find these mutations via the diagnostic tests that we will be reading just now, then you can diagnose the hereditary diseases, and you can apprise the family that as to continuing their marital life and producing children, or take a different course of action. Predicting the prognosis and tailoring treatments, like nowadays we have CFTR modulators available for cystic fibrosis. They are available only if the diagnosis is confirmed by genetic testing. Then comes molecular diagnostics. For example, polymerase chain reaction, PCR. PCR nowadays is done for so many diseases like HLA-B27 is done by PCR. COVID-19, COVID-2, we would do a PCR. So many PCR, HIV PCR. PCR is done lot these days to detect the diagnosis of infectious diseases, or sometimes even the mutation. We try to replicate these mutations more and more so that they become evident clearly under the microscope. Then fish is fluorescence in situ hybridization. So basically we have a defective chromosome. All we do is just try to hybridize it with normal chromosome and make it multiply. So when they are tagged with a fluorescent marker, so when they replicate, they multiply. So what you see is more copies of these fluorescent targeted tagged genes and their chromosomes that you can see in CML. Then nowadays is available next generation sequencing. So these are done in like spinocerebellar ataxia. Unless you sequence these genes, you are not able to diagnose. So high throughput sequencing, or for cancer genomics and rare diseases like spinocerebellar ataxia, these are only diagnosed these days via next generation gene sequencing. So molecular diagnostics, they provide rapid, accurate. I mean, you can have diagnosis within 7 days. So accurate diagnosis essential for personalized medicine. This is something else. Like these are rare patients, like spinocerebellar ataxia is of so many types, and in some types there is treatment available. So not everybody can be given the same treatment. So the personalized medicine, such as identifying actionable mutations in cancers for targeted therapies. Okay. Then comes gene therapy. So this was basically theoretical. Now it is basically being utilized. So in treatment, for example, we see that somebody has a gene which is MSEP. So what we do is we take a virus and we put that gene into that virus's chromosome, and then we let it infect us. So once we are infected, that chromosome is, or that gene is integrated into the human DNA, and then the gene that was deficient in that human, it will be replenished. So that is basically introducing a functional gene to replace a defective gene. For example, ADA gene in SCID. SCID is uh, basically severe combined immunodeficiency syndrome. Then gene editing, CRISPR-Cas9 technology. You can actually cut and remove the defective gene from the genome. Again, that is used to be a theoretical thing. Now it is practically done, and then using viruses to deliver the therapeutic genes. For example, very not very remotely, we will see that viruses are being used to treat cancers, because in cancers we know that multiplying genes, the telomerase is defective. So if the adenovirus or any lentivirus which is used to carry those genes and implant it there, then the replication of the cancer will stop. So the cancer will be there and it will be rendered benign because it cannot multiply. And cancer by definition is unabated multiplication of the uh, cancer cells. So clinical applications now, that approved therapy is there, which is called Luxturna. This is for inherited retinal dystrophy, and gene therapy trials are being conducted for hemophilia and muscular dystrophy worldwide. So these are the gene therapy targets which will be followed in times to come and will be asked in the exams. Then comes pharmacogenomics. So basically, before starting the drug, if we understand that which gene is basically responsible for producing the enzyme that destroys the drug, if that gene is deficient, then there are chances that the drug may have higher side effects. So we know TPMT. TPMT is the most famous enzyme which is tested. It basically, azathioprine metabolism is conducted by TPMT. Imagine if somebody is TPMT defective or negative, then you keep giving them azathioprine. Azathioprine doesn't get metabolized, remains inside, then it will lead to azathioprine, bone marrow depression, liver, dysfunction, and so on and so forth. Same way, cytochrome P2C9 and VKO ORC1 affect warfarin metabolism and dosing. So if somebody is having defective metabolism, then you can expect to give lesser doses of warfarin to target INR. HLA-B variants are associated with hypersensitivity to drugs like abacavir, which is a drug given in HIV syndrome. So these patients develop hypersensitivity reaction, and Steven Johnson syndrome secondary to abacavir. So pharmacogenomics minimizes the adverse drug reaction and optimizes therapy based on individual genetic profile. So we don't, it is not that it is mandatory, but for example, if you want to give somebody primaquine, you need to test them for G6PD deficiency. So that is pharmacogenomics. If somebody does not have G6PD enzyme in them, you are not going to give them primaquine. That patient will eventually develop a crisis, hemolytic crisis, and the patient might die of primaquine induced hemolysis. Then comes molecular oncology. Molecular oncology means that we now try to identify cancers on the basis of molecular genes. Then, if we can identify certain receptors, we can define the prognosis and even change the treatment. For example, there is a breast cancer nowadays which is known as TNBC. TNBC is triple negative breast cancer. Triple negative means HER2 new, estrogen ER/PR, HER2 new, estrogen PR, sorry, HER2 new, and then ER/PR. These are three receptors which are present on the breast cancer. And if the patient is triple negative breast cancer, means all these three receptors are negative, then the treatment is via pogolizumab karke. There is an antibody which is available. But then how do you define which patient needs it? Only via oncogene detection. So if they are HER2 new, ER/PR negative, only then you indicate that treatment in them. So detection of these receptors has helped us to identify newer drugs to be given for cancers and treating them. So oncogenes KRAS, BRAF, HER2 promote uncontrolled cell growth. So whenever we know that patient has HER2 positive, then we have different drugs to treat them. Tumor suppressor genes like TP53, BRCA1-2 mutations can lead to malignancies. If we have found that somebody has BRCA1-2 mutation, then Angelina Jolie, whose mother also had breast cancer, she went in to get her breasts removed as a prophylaxis to breast cancer. And yes, targeted therapies, for example, in Philadelphia chromosome BCA RABL inhibitor, very famous drug, imatinib, is given CML. This is a classical example of molecular oncology. Then trastuzumab, new drug, HER2 inhibitor for breast cancer. Then for melanoma, there is vemurafenib, which is BRAF inhibitor, very good drug for melanoma. Liquid biopsies are done these days to detect circulating tumor DNA. Liquid biopsies are basically getting liquid samples from the body fluid samples to detect the tumor DNA circulating. Once you have that DNA, you can always check which gene is there, which is defective or absent or present. Then you can take a call on treatment. And then also you can later on, after treating the patient, you can check if the relapse is there. Because if the DNA of tumor is there, then definitely there is some tumor cell which is growing up. And the benefit of biopsy doing the PCR on the fluid which you have taken by PCR will help you detect even minuscule DNA segments of that cancer, detecting early recurrence. Then epigenetics. Epigenetics is basically uh, a very important branch which has been used now for lot of time, but not, it has not been put into the necessary perspective. For example, methylation, DNA methylation. Some gene, DNA methylation is used to silence the gene expression frequently altered in cancer. So many drugs like paclitaxel, cisplatin, they are used in treatment via DNA methylation. Then histone protein methylation modification. For example, histone proteins are required to keep the DNA in place. They are integrating proteins. So whenever you change them, then definitely they affect the way the DNA will be either replicated or transcripted. So it is such an important mechanism now to treat via histone modification. And then definitely giving a non-coding RNAs called microRNAs. Very soon we will have lot of cancers being treated via microRNA particles. So they regulate the gene expression post transcriptionally. Now let us say if the cytoplasm has enough, it has now been found that whenever the protein concentration, certain protein concentrations, they go down in the cytoplasm, there is a feedback mechanism by which the cytoplasm tells the nucleus that now the DNA needs to produce more RNA so that the protein is replenished. Now these non-coding RNAs, if we throw them into the cytoplasm via virus or something, then the those feedback stimulus is not given to the nucleus at all. So the DNA will not replicate. And as we know, cancers are all DNA replication, so we can stop their replication. So these epigenetic therapies include azacitidine. Now azacitidine is drug of choice now for which condition? Anyone? Azacitidine, it is a standard question, comes in almost every exam. Azacitidine is now a drug of choice for, there is a bone marrow disorder which is treated with azacitidine. That is myelodysplastic syndrome. Sometimes you have patients who have persistent leukopenia, persistent anemia, and you identify these patients via their bone marrow. You find that there is a hypercellular bone marrow. So there is multiplication of abnormal cells which are not amounting to cancer, but they are amounting to dysfunctional peripheral blood smear, that there is no enough WBC is no enough, RBC is no enough, platelets. So bone marrow failure eventually happens. And azacitidine is drug of choice which is given in bone marrow depression due to this condition known as myelodysplastic syndrome. Same way, HDAC inhibitors which are used in hematological malignancies. Is that clear until now? Then comes CRISPR and genome editing. Now this is very important. Now all exams, be it Australian Medical Council exam, USMLE, Mrcp, PLAB, all of them are asking these questions because this is something new. CRISPR-Cas9 system. So this is basically scissors. We call them micro scissors. So these Cas9 endonuclease, which is known as micro scissor, the question comes as these micro scissors are which enzyme? So if you have not read about it, then you will not be able to answer it. It is the micro scissors are known as Cas9 endonuclease. It cuts the DNA at specific sites directed to by guide RNA. Applications are correcting genetic defects like sickle cell disease, creating disease models, and potential cancer therapies. So editing germline cell raises concerns about unintended mutations and long-term effects also, but the science is progressing towards it. So CRISPR is basically clustered, regularly interspaced, short palindromic repeat sequences. So this is revolutionary gene editing technology that allows us to do precise modifications in the DNA. It is based on natural defense mechanism found in bacteria, which is Cas proteins, that is CRISPR associated proteins like Cas9 to cut viral DNA and protect against infections. So it is helping us to do something known as genome editing. Now, this genome editing refers to techniques that enable targeted changes in organisms' DNA, including inserting, deleting, and modifying genetic sequences. Basically, we are now the mutators. We can mutate the gene by ourselves. We can do that. So this CRISPR-Cas9 is the most widely used genome editing tool because of its simplicity, efficiency, and precision. Mind you, there are chances that you might get some questions from CRISPR. How does it work? Basically, there is a guide RNA known as gRNA, a designated RNA sequence which guides the enzyme to a specific DNA sequence. So it basically, you can see that this is the engine and this is the bogie. So this engine is basically a guide RNA. So it is taking this Cas9 enzyme to specific DNA sequence, and this enzyme acts as a molecular scissor to cut the DNA at target location, and later on the cell repair the cut through by itself with the help of non-homologous end joining NHEJ, which can lead to gene disruption, or homology directed repair, which allows precise genetic modifications using a repair template. What are the uses? Very important uses in treating sickle cell disease, cystic fibrosis via the mechanism of gene therapy. Cancer research is important. Agriculture, creating disease resistant crops, and infectious diseases like potential to edit the viral genomes and engineering these details. So, but because we are trying to act God here, that is why there are concerns by the ethical committees worldwide, because it can have a long-term effects. Mitochondrial genetics. Now, mitochondrial genetics is basically maternal diseases, for example, LHO and Leber hereditary optic neuropathy and Melas syndrome. There are so many of them. So these diseases are basically from the mitochondria. And as we know, this is the ovum. This is the ovum. This is its mitochondria. And this is the sperm. And this is the sperm mitochondria. So when the sperm enters into the ovum, basically it leaves its mitochondria outside and enters into the ovum. So basically, the father never gives their mitochondria to the children. It is the maternal mitochondria which is inherited. So basically, these are if the mitochondria is defective, then the rubral fibers defect. This myopathies, they occur because muscles are basically where the most mitochondria are there. So they lead to maternally inherited diseases, which basically are about the respiratory chain, because mitochondria are obviously the respiratory kings of the cell. So mitochondrial disorders are like Lehon, Leber's hereditary optic neuropathy, Mela syndrome. Then heteroplasmy, for example, presence of both normal and mutated mitochondrial DNA within the cells influencing disease. So this question has been asked so many times that not all patients of mitochondrial disorder presents with same level of disease. That is because some mitochondria might be defective, some mitochondria might be normal. So if the percentage of normal mitochondria is more than the defective ones, the patient may be asymptomatic. But if the defective mitochondria concentration is more, then the patient will be having severe disease. So muscle biopsy and genomic sequencing, next generation genomic sequencing and muscle biopsy are required for mitochondrial DNA analysis. Okay, now let's go through some questions which will be helpful for you to revise this topic. It is not a boring topic, it is interesting, but all you have to do is put your mind into it. So we have a 34-year-old man with CML started on imatinib. Which molecular target is inhibited by this drug? We know BCR ABL gene is inhibited. Which drugs are JAK2 inhibitors? Anyone?
JAK2 inhibitors are this tofacitinib.
Okay. KRAS inhibitor? Anyone? So this is our way of revising molecular genetics. KRAS inhibitors? Anyone? So KRAS inhibitors, basically they are custin rat, sarcoma, viral oncogene homologue. So sotorasib is the drug which is used these days, and it is basically made for non-small cell lung cancer, NSLC. So non-small cell lung cancer के लिए it is used. It is known as sotora, और भी होंगे, but you please find out. So sotorasib is a drug which is used for treatment of non-small cell lung cancer. Basically, this is the cancer in which KRAS is more amplified and shown. What is the drug that blocks HER2?
Trastuzumab.
So trastuzumab. EGFR. अभी तो देखा था हमने.
Some pancreatic.
So again, tyrosine kinase inhibitors and monoclonal antibodies like erlotinib, these are used. Okay. So EGFR is epidermal growth factor inhibitors. So basically they are manifested in colorectal cancer, non-small cell lung cancer, head and neck squamous cell cancer. So they are of two types, these EGFRs. They are of two types. One is very famous, which is tyrosine kinase inhibitors. And then there are monoclonal antibodies which are used these days, MABs. Okay. So the monoclonal antibodies that are used, as I was telling you, they are, in cetuximab is the drug which is used. Cetuximab, very important drug. Cetuximab nowadays in this world, it is basically given in wild type of, very specific wild type colon cancer, colorectal cancer. Okay. So you need to be ready for any kind of questions. But then whenever you see some answers, one answer the other answer you should always just go visit, maybe online, maybe make notes, so that which are the other things which are mentioned in the question. Which techniques is most commonly used for detecting point mutations in the genes? So point mutations are just changes in the one amino acid or the one nucleotide. So polymerase chain reaction is the standard test to use these point mutations. So PCR is highly sensitive for detecting point mutations, deletions, insertions, making it essential for molecular diagnosis, including cancer, genetics, and infectious diseases. So by the time for example, like COVID changed itself so much, Delta variant, Flana variant, so many variants, they were all being diagnosed by PCR because any small change can be detected by PCR. A 45-year-old woman is diagnosed with HER2 positive breast cancer. Which monoclonal antibody is used in her treatment? Rituxi, cetuxi, bevacizumab, trastuzumab, pembrolizumab. So what is the answer?
Trastuzumab.
Trastuzumab. Okay. What is pembrolizumab? This is the drug which has taken the world by surprise. It is very expensive drug, routinely used in, which I was telling you, TNBC. Triple negative breast cancer. Drug of choice in triple negative breast cancer is pembrolizumab. Okay. Then comes cetuximab. I just told you cetuximab is basically
response. Okay.
So this is EGFR, cetuximab. EGFR, that is epidermal growth factor receptor inhibitor. It is the cetuximab which is used for wild type of colorectal carcinoma. Rituximab, you all know,
Yes.
it is CD20 inhibitor used in the treatment of autoimmune disorders, for example, rheumatoid arthritis, neuromyelitis optica. There's so many autoimmune conditions with rituximab, so many glomerulonephritis which are treated with rituximab these days. Which of the following is an example of gene therapy? Use of antibiotics in bacterial infections, insertion of a functional gene to replace a defective one in SCID, administration of monoclonal antibodies in lymphoma, use of statins in hypercholesterolemia, using beta blockers in hypertension. So what is the answer? So
Second
the
one.
answer is insertion of a functional gene to replace a defective gene. So that is a gene therapy where we are handling genes. So insertion of a functional gene. Gene therapy, we've already discussed. For example, which gene is used? It is ADA gene. So we just replace the ADA gene in severe combined immunodeficiency syndrome. Okay. Pharmacogenomics is best described as number one, a study of drug interactions, number two, genetic basis of disease inheritance, number C, influence of genetic variation on drug response, um, number D, use of molecular markers in disease diagnosis or study of drug metabolism enzymes. So what is pharmacogenomics?
Influence of genetic variation on drug response.
Yes. So basically we try to identify, for example, isoniazid, slow acetylator, fast acetylator. We all know about that. So influence of genetic variation. Some people are fast metabolizers, some are slow metabolizers. In fast metabolizers, there are chances of drug failure. And in slow metabolizers, there are chances of drug toxicity. Same way, if the drug metabolism leads to a molecule which is very, very dangerous, then people who are fast metabolizers, they will have higher incidence of side effects because of that typical byproduct of the metabolism. Is that okay? So a patient with cystic fibrosis is found to have delta 508 mutation in the CFTR gene. What is the molecular defect? What is the answer? So it is a small mutation, deletion of phenylalanine at 508 position. So there is deletion of phenylalanine. So this delta F08 mutation is most common in cystic fibrosis, causing defective CFTR protein folding and chloride transport, leading to thick mucus everywhere. Which molecular technique uses fluorescent probes to detect specific DNA sequences on DNA? I told you where the fluorescent probes are used.
Fish.
Fish. So its name is fluorescence in situ hybridization. So it is used for genetic mapping and trying to identify the defective genes in the body. Okay, which enzyme is used in the CRISPR-Cas9 system for genome editing? Basically, the question is which enzyme is known as microscissor? Answer is
Endonuclease.
endonuclease. So the answer is Cas9 endonuclease. It is basically used for precise editing of the DNA sequence. Lynch syndrome is an inheritable syndrome, is associated with mutations in which type of gene? Very common, very, very common. So basically there are some mismatch repair genes. Which one are defective? They lead to abnormal matching of the chromosomes. One unites with two, two unites with three. So basically one unites with one from mother, one from father. But then one unites with two, different chromosomes. So these genes, they don't match up together. So mismatch repair gene is affected in Lynch syndrome. So there are multiple cancers. There is microsatellite instability. There is multiple cancer leading the bunch of the cancers is colorectal cancer, which is much more in Lynch syndrome. So Lynch syndrome is basically defective mismatch repair gene. Lynch syndrome is caused by mutations in them. MLH1. There are so many names of this, leading to microsatellite instability and colorectal cancer. So Lynch syndrome has this problem. Which molecular biomarker is used to monitor treatment response in prostate cancer?
ESA.
Wonderful. What is CA125?
This is one ovarian, I think.
Ovarian cancer. What is
Right.
alpha fetoprotein?
Hepatic.
Hepatic cancer. So hepatocellular carcinoma. Okay. CEA,
PA is colon.
colon cancer. HER2 is
Breast.
breast cancer. Very good. Which molecule is most commonly analyzed in liquid biopsies for cancer monitoring? अभी पढ़ाया था मैंने. So what do you do in liquid biopsies? You do PCR on what?
ctDNA.
So you find out circulating tumor DNA and then you amplify it. So the answer is ctDNA. Liquid biopsies detect ctDNAs in blood, providing a non-invasive method for cancer detection, prognosis, and monitoring treatment response. The Philadelphia chromosome. One word answer quickly.
922.
Okay. Anyone can tell about 814?
814.
Edward.
No, 814 is.
Is it Burkitt's lymphoma?
Yes, yes, Barkett's lymphoma.
Okay, great. Which epigenetic mechanism involves the addition of methyl group to DNA? It's a simple one.
DNA.
Histone methylation.
So what we DNA methylation? No, not histone.
Yes.
DNA
It is
methylation.
DNA methylation.
So DNA methylation silences the gene expression and plays a crucial role in gene regulation. So all you have to do is put a methyl group on the DNA and then it fails to show its effect. It doesn't get identified by the enzymes. Which molecular method is used to amplify the specific segment of RNA?
RT-PCR. RT-PCR, sir.
So the answer is RT-PCR. Western blot is used to amplify what?
Forgotten, sir. System. Northern.
So basically, Western blot is
Protein.
used to amplify proteins. There
Yes,
is
sir.
no role of RNA, DNA, or anything. It basically amplifies or basically detects proteins. Okay. What about Northern blot?
That's RNA.
So basically, we use Northern blot to quantify RNA. To amplify RNA, we need RT-PCR. So so this is basically amplify RNA or DNA. Western blot is to quantify protein detection. Northern blot is basically for quantifying RNA. So is there any disease where you are quantifying RNA?
Hepatitis C.
Very good. So also you do that. I'll give you a question. Basically, someone, a researcher, a scientist, a student is studying the expression level of BCR-ABL fusion transcript. So basically, RNA ho gaya na? Fusion transcript in a patient of CML. Which of the following techniques would be most appropriate for detecting and quantifying BCR-ABL mRNA? Same options. What will be the answer? Quantify karna hai.
Quantifying.
Northern blot.
So the answer will be
Northern blot.
Northern blot. Very good. So this is how the questions will come. Reverse transcriptase converts RNA into complementary DNA before amplification, used in viral diagnostics like SARS-CoV. And Western blot is basically used to define. I'll make a table for you. You can take a photo. So basically, Southern blot is for DNA. We use DNA probes in it. Coming to the Northern blot is for RNA. We use DNA or RNA probe in it. We can use both because ultimately you just have to identify. Then comes Western blot. So Western blot is for protein detection. Which proteins usually you want to detect? You want to detect antigens or antibodies. Okay. Then there is a last one is Southwestern blot. Can anybody tell me where it is used? It is basically DNA binding proteins because it's a Western blot, and Southwestern blot means DNA binding protein. And it uses a DNA probe. Is that okay?
Yes, sir.
Great. So we move on to next question. Okay. So a patient with melanoma is found to have BRAF mutation, which is V6OOE. And which targeted therapy is indicated in this? We've done this question. This is just a revision. When we were doing whatever difficult names are there, they are very easy to remember because of their associations. So I told you I only told you two of them. So this is Vemurafenib. Yeah. So Vemurafenib. So it is a BRAF inhibitor used in melanoma with BRAF V6OOE mutation, improving survival outcomes significantly. So these are where did we study? Yeah, here. You can take a snapshot of this. So Imatinib is BCRL inhibitor, Trastuzumab HER2, and Vemurafenib is BRAF inhibitor. Don't forget this. Okay, Vemurafenib, BRAF inhibitor. Now coming to next. Which inherited disorder has a trinucleotide repeat expansion? It's a takeaway. It's Huntington's disease, CAG repeat.
Disease.
Yeah. So which are other CAG repeat disorders? You are all prepared for exam very soon, right?
Please repeat again.
The question?
Yes, sir.
Yeah. Which other disease are
Trinucleotide repeat.
Trinucleotide repeat disorders?
Myotonic dystrophy.
Okay. So we start with Huntington's disease, then
Myotonic dystrophy.
Myotonic dystrophy. I think.
Cerebrospinal.
Yeah.
Spinocerebellar
Spinocerebellar ataxia is there.
Yes, sir.
Then basically muscular atrophy of any types. Nowadays, they are all trinucleotide repeats. There is very important concept in it. I think you attended that class where I told about trinucleotide repeat disorders. There is a trinucleotide repeat threshold. It is known as repeat threshold. So what happens is, as the generations move forward, the thresholds, they keep multiplying, and the father, let us say, had the onset of disease at 50 years. The son will have the onset of disease at let us say 45 years. His son will have disease onset pretty early because the repeats will continue to increase. They might have a 30. What is this phenomenon known as?
Genetic anticipation.
Wonderful. So this genetic anticipation is a concept in trinucleotide repeat disorders only, because as the generations, they progress from one to the other, the trinucleotides, they keep on adding. Okay. So in pharmacogenetics, which gene affects warfarin metabolism? So the answer is cytochrome P to 2C9. Okay, great. Which mitochondrial mutation is most commonly associated with Leber's hereditary optic neuropathy? tRNA, ATPase gene mutation, ND4 gene mutation. Somebody will have to, pick up an answer based on the knowledge that this disease is a mitochondrial disease. So the answer is ND4 mutation. This is particularly, you will need to remember this. So this ND4 is important in the, high energy requiring systems. So which are the highest energy requiring systems in our body? Number one is the eye, because eye is always looking at something and processing the data. So it is the very high oxygen consuming areas. So whenever there is mitochondrial dysfunction and there is ND4 gene absent, the optic nerve degeneration is there, because it just undergoes basically disuse atrophy. So the optic nerve, it goes away. Is that clear? So it is not difficult to remember. ND4 is the gene which is involved in the LHON, which is Leber's hereditary optic neuropathy. Which technology enables the throughput sequencing of entire genomes, where you can just, you can just analyze total genome of a person? That is next generation sequencing. I told you now, for example, in spinocerebellar ataxia these days, next generation sequencing is done by the companies which are providing trial drugs. So they provide the genome and generation sequencing free of cost, just so that their drugs can be sold. So next generation sequencing is the answer, because NGS allows for rapid large scale sequencing of whole genomes, exomes, or specific gene panels. Very important. Which genetic test is used to diagnose Fragile X syndrome? Karyotyping, FISH, Southern blot, PCR, microarray. Anyone? What is the answer and why? So Fragile X syndrome is a trinucleotide repeat disorder. Is that clear? ये तो पता है ना? We know all of this. Hello?
Yes, sir.
Yeah. So the Fragile X syndrome is basically a CGG, CGG repeat disorder. So whenever there is a repeat expansion or repeat disorder, all you want to do is you want to understand the DNA, okay? Because it's there is a trinucleotide repeat disorder. You want to see the trinucleotides. So you not only want to diagnose that this is a trinucleotide repeat disorder, but you also want to see if amplification is going to happen by counting the threshold, trinucleotide repeat threshold. Which can do that? Only Southern blot can do that for you, because Southern blot will identify not only the repetition of the CGG, it can even count and let you know that how many repeat expansions are there. So Southern blot detects the CGG trinucleotide repeat expansions in the FMR gene, and which is obviously the cause of Fragile X syndrome. Now, important is for us as doctors and scientists, why not karyotyping? Many of you would want to ask, why not karyotyping? Because that also detects. So why not karyotyping? Because karyotyping, what anybody can tell me about karyotyping? Karyotyping is chromosomal analysis.
All analysis.
So chromosomal analysis means we are just going to count the number of chromosomes. If it was Down syndrome, I was okay with karyotyping. But it is a trinucleotide repeat disorder where I need to go further into the system to see if the DNA is all right. And if it is not all right, if there is a trinucleotide repeat, I want to count the sequences. Is that okay?
So in this question, had this been replaced by just say like Huntington instead of Fragile X, would the answer be the same?
Yes.
Okay, sir.
So as far as FISH is concerned, FISH is basically again, for deletions or translocations. So we can see the translocations of genes. We cannot see the nucleotide level of them. So from chromosome, we came down to genes. So the genes got translocated. or the chromosome got translocated. We know BCR-ABL gene, there is a translocation between 922. So that can happen. So CML, fish is okay. Okay. Then per this PCR, polymerase chain reaction, this. So polymerase chain reaction, it can help, it can actually help, but uh, the basic competition here will remain between southern blot and PCR. PCR can help to diagnose. Definitely, it can be helped to diagnose. Why? Because in the PCR you can see the CGG repeats because polymerase chain reaction. So you can, but what you cannot do is you cannot count because PCR will amplify them. Do you understand?
So please repeat again.
Yeah. So PCR, let us say PCR in itself is basically polymerase chain reaction. So
Yes.
PCR is amplifying whatever DNA is there in the solution.
Okay.
So let us say if the patient had 10 CGG repeats and PCR amplified it to 100, you will count 100. So you will overdiagnose the condition. You will not get the absolute, repeat expansion number, the threshold. You will not get it. Why? Because PCR will amplify it so much so that the patient will be there and he will be asymptomatic and you're just working up the patient. And according to the PCR, the patient should have symptoms by now because amplification should have happened. But it is not the natural amplification that is being counted. It is the PCR induced amplification that you are counting. Are you getting me? Because PCR, the mechanism of the test itself is amplification. So if somebody is not born with the amplification, is born with maybe just one CGG repeat, PCR will show that as if they have 100 repeats because it has already repeated it, amplified it 100 times. So that is why PCR is used to detect even small amounts of DNA because it can amplify it to a level where it can get detected. Okay?
Yes, sir.
So,
Got it.
yeah. So PCR will not be the answer. And southern blot will be the answer because southern blot and PCR, in southern blot, you are only concerned about the DNA. You count everything. So southern blot is a difficult test to do. PCR is a very easy test to do. All you have to do is just put in some polymerase enzyme into the system and let it multiply the DNA. You cannot stop the multiplication because you have added the enzyme. It will just continue to amplify whatever DNA is there. So that is all for today. This is about molecular science. So I'll just take you to the first page again because that is where everything is. These are the main key topics which are important in molecular medicine and everybody should know. And you can actually, just work these things up. You can check them online or you can just see. I mean, you don't need to become a molecular genetist or a scientist for that matter. You just need the information for clearing an exam. So just mark this thing down: genetic basis of disease, molecular diagnostics, gene therapy, pharmacogenomics, molecular oncology, CRISPR and genome editing. I can drop the this class with Sana, so you can take it from her, and so that it will help you just to again reposition yourself where you are as as relating to this topic. It is not a difficult topic, but all you need is like, don't be scared of it. Just go forward. It is an enjoyable topic, and it is a topic of future, I must say. So the futuristic medicine will be practiced on the genes basis. So very small topic now, but then it might become one of the important topics in coming years. If there are any questions, we can take them now.
Aspirants, if you have any question, please bring it up now, or else we'll discuss in other class. Let me know.
So what I'll do is, Sana, I'll send you this class.
Sir, if you
Sure,
don't
sir.
mind, sir, if you don't mind, can you give us your mail ID? If I have question, we can ask you.
Yeah, you can drop in with Sana. I can reply in WhatsApp to Sana. I mean, Sana will have to mediate it. Yeah.
Okay. And I have to make an announcement that as many know that we are having a 3-day PACES course in KPC Medical College.
right? Where all the MRCP faculties will be present with us. Varun Pushkarna sir will also be there. So I'll send the flyer in the groups. Please circulate it with your friends and colleagues. If anyone need us, we'll be there to help. Thank you.
Thank you, Sana. Thank you, participants. Take care. Have a nice weekend.